I know many of you, but for those of you I don't know, I'm Casey Ledger. I'm one of the faculty here, and I focus on pediatric leukemia and lymphoma. And we're going to just talk about the basics of pediatric lymphoma today. Feel free to stop me at any point if you guys have any questions. And I should not take a full hour for this presentation, so hopefully you won't be too disappointed if you get out early today. Okay, so our learning objectives, are to understand the main types of lymphoma, understand the presenting signs and symptoms, and how these vary by subtype, and then understand the approach to therapy, along with the expected toxicities that we'll see with each of these. So I'll start by talking about what the different lymphoma types and subtypes are, talk about the epidemiology, and then start with Hodgkin's lymphoma, talk about presentation, workup, and treatment, and then do the same for non-Hodgkin's lymphoma. And I've got just a slide on each of the different sort of subtypes of non-Hodgkin's lymphoma at the end. So these are the two divisions of lymphoma. So you've got your Hodgkin's lymphoma and your non-Hodgkin's lymphoma. There are varying types of, let me see, is this actually, oh, look at this, so fancy. Okay, so along this column here, you've got your classic Hodgkin's lymphoma and the different pathologic subtypes, and then you have your nodular lymphocyte predominant lymphoma, or Hodgkin's. And then of the non-Hodgkin's lymphoma, you've got a number of different types of subtypes, and they're all treated fairly differently. And then you have your sort of more indolent lymphomas. These are a lot more common in adults. We sort of rarely treat indolent lymphomas. And then things like PTLD, or post-transplant lymphoproliferative, that's also classified under non-Hodgkin's lymphoma. So we'll kind of talk about what each of these are. So I think it helps to think about the cell of origin. So when we're talking about lymphoma, you're talking about a cancer of a white blood cell that is starting in the sort of lymphatic system, as opposed to a leukemia where you think about a cancer of the white blood cell that's starting in the bone marrow. There's not always easy sort of distinct cutoff between what's a leukemia and what's a lymphoma. We typically use the definition of having 25% blasts in the bone marrow, or 25% leukemia cells, to sort of distinguish whether or not the cancer sort of started in the bone marrow and then kind of went out of the bone marrow and through your kind of lymph system, or if it started on a lymph node and then spread to the bone marrow. But I think that's always sort of a conversation that we have as a provider team of, like, is a patient that has 20% leukemia cells really that different than a patient that has 25%? And sort of how differently should we think about the approach? And most commonly we'll see this in lymphoblastic lymphoma, which is very similar to lymphoblastic leukemia, or ALL. And the treatment between lymphoma and leukemia in that setting is not very different. We'll talk a little bit about that. But in any case, we're talking about a cancer of the white blood cell. And so, and specifically your lymphocytes. And you have T lymphocytes and you have B lymphocytes, and then you have immature and mature lymphocytes of origin. And so when we're talking about immature, you're talking about either your T or B lymphoblastic lymphomas. When you're talking about your mature T cell, you're talking about anaplastic large cell lymphoma, and then your mature B cell derived are all the rest of them. So your Burkitt's, your diffuse large B cell, primary mediastinal B cell, and then Hodgkin's lymphoma. And they're all differentiated by what the pathologists are telling us they see under the microscope when they look by flow cytometry at what the cancer cells are expressing on their cell membranes, and then what the sort of cytogenetic or DNA findings are. So you can see that lymphoma is quite common in pediatrics. So it's the third most common type of pediatric cancer, and in our adolescent patients, it's the most common. So it's seen in 25% of adolescents, 15 to 19. The sort of talking about the incidence of the two subtypes by age, so you can see that the blue is non-Hodgkin's lymphoma, and it's much more common when you're in these younger age group. If you are presenting with lymphoma, you're much more likely to have the blue non-Hodgkin's lymphoma than you are the red. So we almost never see Hodgkin's lymphoma in these really young ages. And then once you get to about 10 years of age, they start to overlap. So in a 10 to 14-year-old age range, the patient is equally as likely to have Hodgkin's versus non-Hodgkin's lymphoma. And then you see the proportion of Hodgkin's lymphoma go up in adolescent and young adulthood. Okay, so then thinking about the subtypes of non-Hodgkin's lymphoma based on age of diagnosis, this also varies. So I talked about how non-Hodgkin's is much more common in the young kids. And then if you think about non-Hodgkin's lymphoma, I mentioned that adults or that pediatrics are a lot less likely to have these indolent lymphomas, which is more common in adults. So 95% or more of patients will have some aggressive subtype of NHL. And you can see the sort of distribution. Burkitt's and diffuse large B-cell, we sort of think about interchangeably. We treat them on our same exact protocol. The only difference is that the Burkitt's have this cytogenetic c-MYC translocation, and the diffuse large B-cells do not. And then you have, so that's 60% of lymphomas in the young age, and then the rest are mostly lymphoblastics, and then you have some of the ALCLs. So these are a lot less common. And I think this is probably what you guys are used to seeing if you think about the patients that you're taking care of. I think definitely you're most likely to see these patients that are getting therapy for their mature B-cell. And then you can have your non-Hodgkin's lymphoma associated with immunodeficiencies. And that is just because your sort of T-cell function in regulating abnormal lymphocyte proliferation can be preventative in developing malignancies. And these pie graphs, I don't expect you to sort of study in detail, but it just kind of shows you of all the different non-Hodgkin's lymphoma subtypes, there's certainly variable distribution of the subtypes across the different age groups. So now we're back to looking at Hodgkin's lymphoma. So there is some type of genetic predisposition to Hodgkin's lymphoma. I think we don't really know what it is. Hodgkin's is not part of like the P53, Lee-Fraumeni syndrome. Most of the cancer predisposition subtypes don't include Hodgkin's lymphoma, but there are certainly higher risks for patients who have siblings that have Hodgkin's lymphoma. And like in here, it says monozygous twins. They're 99 times higher at risk for Hodgkin's lymphoma. So there is some kind of underlying genetic predisposition for developing Hodgkin's. We do know that immune function has a role in both the development of Hodgkin's, but then also in its sort of pathogenesis, because patients can present with different immune-related phenomena. So in this letter column here, they're talking about you can present with ITP, autoimmune neutropenia, even nephrotic syndrome we've seen in some patients, which is immune-mediated. And then I think this last bullet is interesting. So there's a childhood form of Hodgkin's lymphoma and an adult form of Hodgkin's lymphoma. And so even though it's very rare to have younger kids with Hodgkin's, it does seem to be associated with lower socioeconomic status, larger family, and sort of early, more intense exposure to infections. And that's the complete opposite, of the young adult form, where it seems like protection from infection through higher socioeconomic status, single-family homes, small family, less siblings, less daycare, things like that. Those patients are actually at higher risk for infection. So I don't think we exactly know how to explain these differences, but I think it's certainly something that has been described epidemiologically. So I'm going to start with Hodgkin's lymphoma and just talk about kind of the workup, staging, and treatment. So Hodgkin's, as opposed to the aggressive non-Hodgkin subtypes that I'm going to talk about today, are very slow-growing tumors. So it's not uncommon to have a patient come in and say, I've had this mass in my neck that's been growing for the last 6 months, or I've had 6 to 12 months worth of symptoms. We had a patient come in with almost a year of itching that is sort of a rare effect that Hodgkin's can present with. So these patients will have very slow-growing tumors that develop over time. And you can see kids present with really impressive, bulky adenopathy, huge mediastinal masses. And they can present symptomatic with difficulty breathing when they lie flat and can have a lot of compression in their airway. They can have like SVC syndrome, things like that. But it's not like that happen overnight. Oftentimes it just happens so slowly that their bodies are compensating until they sort of reach this critical mass where they are sort of finally symptomatic and can't really deny what's happening in their body. So you've probably heard us talk about the sort of constitutional symptoms that come along with Hodgkin's, and we talk about your staging, but we also we call it a like stage 4A versus 4B, and that just speaks to whether or not there's constitutional symptoms present. And so the 3 classic constitutional symptoms are having a weight loss of more than 10% in the last 6 months, having drenching night sweats, and this is I am like waking up and having to change my shirt or my sheets because they're drenching wet, not like I woke up and feel a little bit clammy. And then unexplained recurrent fevers, more than 38 degrees in the preceding month. If they have like a virus or something that they're presenting with, that's an explanation, and so that wouldn't necessarily qualify. And then other things that are noted but are not used in the classification of this A versus B staging is fatigue, anorexia, weight loss, that's more mild. Pain following alcohol is one that I think is less seen in our population, but certainly recognized. And then I already mentioned this pruritus or itching. And then patients will often present with evidence of inflammation with a high ESR or CRP. They can present with anemia just from the effects of chronic inflammation. And then I already mentioned this immune dysregulation. And here is sort of your classic patient with Hodgkin's lymphoma that presents with a mediastinal mass. So this is a CAT scan. This is their lungs, liver, their stomach, and then here's their heart. And typically you have like a sort of a narrow heart border with a little bit of kind of thickening around your esophagus and your aorta. And this is obviously much more than a little bit of thickening. So this patient would have an anterior mediastinal mass, and this would be considered bulky mediastinal disease, which is something that we think about in their staging and risk stratification. So if you think about a patient with this CT scan, what might be on your differential? So there are some things that are non-oncologic, like infection. Normal thymus is one that, especially at adult centers where they're not used to seeing kids that have pretty robust thymuses. I don't know how to say that plural term, but sometimes even a little, like the presence of a thymus, outside adult radiologists will call a mass, and actually it is normal thymus. But pediatric radiologists are usually really good at differentiating, and certainly a CT scan like that is not thymus. So it's sort of a little bit of mild thickening that you might see. And then all of the malignant differentials are basically lymphoma, except for these couple down here. So we've had a recent germ cell tumor that was admitted to the orange team being worked up for lymphoma that ended up having a mediastinal germ cell tumor. Oftentimes the germ cell tumors will have certain radiographic features that we can sort of have clues that it's something else like calcifications, but we don't always know. Okay, so in terms of thinking about workup, there's a number of labs. We get a chest x-ray, we get CT imaging, and we do neck to pelvis because they can have lymphomatous involvement in any of their lymph nodes in those regions. And then we do a PET scan, and I'll show you an example of that. And then we also get a biopsy, so that's kind of the only way to know what you're dealing with. And then we used to do bone marrow biopsies, but PET scans are actually really good at diagnosing bone marrow disease, and so we don't always do this. For example, in Hodgkin's lymphoma, we're kind of getting away from that, but there are still some of the non-Hodgkin's lymphoma where we'll do bone marrow biopsies, and we always do those bilaterally because you can have kind of spotty, patchy metastasis to the bone marrow, different from leukemia, where you expect that the whole bone marrow is being replaced by the leukemic population. So this is a PET scan. And different from the CT imaging where you're trying to get a detailed look at the kind of anatomy and the lymph node morphology and kind of how big the lymph nodes are, this is actually showing you the metabolic activity. And so you can see these sort of bright yellow spots are the places that tumor cells are rapidly growing. They need sugar to grow, so there's a sugar linked to a nucleoside tracer, and so spots where there's lymphoma cells that are rapidly turning over and taking up sugar light up very bright. And so that is very useful to us in staging, specifically of Hodgkin's, but also in non-Hodgkin's. And then this is our staging classification. So we start with Hodgkin's, assigning a stage. And stage 1 or 2 is when you have kind of a single lymph node or a single lymph node chain. Stage 2 is when you have a couple of adjacent chains involved. Stage 3 is if you have above or below the diaphragm. And then stage 4 is metastatic disease to the bone or the bone marrow, or liver, one of the solid organs. And then you classify it into into A or B, like I said. And so then you have your stage and your A and B. We also look at whether you have bulk disease. So this is defined in the mediastinum just by chest X-ray. It's greater than a third the width of the diaphragm, so the providers determine that. Or this, the bulk, the length of your nodal mass if it's outside of the mediastinum. And so we decide if it's bulk disease, the stage A and B, and then we assign them to either low, intermediate, or high risk. And then there's this other sort of subset, lymphocyte predominant, which is treated a little bit differently, and I'll talk about that in a second. So you can see that there's sort of a division between each of the different risk strata. And the outcomes are all really good. Hodgkin's lymphoma cure rates are pretty fantastic. The high risk, it's as low as 80%, and these are the EFS stands for event-free survival. So this is the likelihood of surviving without having relapse of your lymphoma. And then overall survival is speaking to if you do have relapse, your likelihood of kind of surviving beyond that. And so the nice thing about Hodgkin's is that it's not only very highly likely to be successful with the first attempt, but there's also a lot of good salvage chemotherapies, and so the patients have pretty good odds of being cured even in the relapse setting, which is different than a lot of other diseases. So then this last subtype, lymphocyte predominant. So this is the one when we get a path report in Hodgkin's lymphoma that we actually will impact the way that we think about it and the way we treat it. This is the one type of Hodgkin's lymphoma that we consider curable by surgery only. And that is in the setting of having, oftentimes they present with one big solitary lymph node, sometimes in a couple of adjacent lymph nodes. But if you have a single lymph node that's involved and you cut the whole thing out, then you're done. And you don't need to do chemotherapy. They did a study through the Children's Oncology group and found that with this approach, 75% of kids were cured, and 25% ended up having recurrent disease at that same site, and then found that with chemotherapy, they could get those patients cured as well. So the overall survival rate was 100%. So this is a very favorable subset. It is more common in male. You can see 75% are males. Like I said, it's usually localized and not often associated with the B symptoms. Okay, so thinking about therapy, I've mentioned a couple of times now that Hodgkin's is very curable, that we have a lot of very good therapy. The problem is that that cure comes at a cost because we use a lot of chemotherapy and historically have also used radiation. So based on what I showed you a minute ago with the different risk strata and all the different aspects of your staging, we give sort of varying numbers of cycles of chemotherapy and different intensity of cycles. And the approaches, because cure rates are so good and the toxicity long-term is so high, the recent trials are trying to look at new agents that will allow reduction of chemotherapy so that we can maintain cure rates without having all of the long-term toxicity of all the chemotherapy that we're giving. And then radiation is very effective in Hodgkin's, but it also has a lot of morbidity long-term. So it has a high rate of second malignant neoplasms. We're oftentimes radiating this like mantle location where you have your thyroid, you have breast tissue, mostly that impacts females, but males are at risk for breast cancer as well. And so I think over time we have tried to decrease the patients who are getting radiation. So these are the drugs that we give on our local BAT, although I will say that we have 2 Hodgkin's trials from COG that are about to open. And so the therapy that you guys will be seeing is a little bit different. Actually, the adult therapy is called ABVD, which is sort of similar classes of agents, but a little bit different, and it's given outpatient. And so these Hodgkin's admissions that you guys are used to taking care of, you may see a lot less of. This is still our institutional standard, though. So these are the different, I think there's, 6 drugs here that is part of our BAT. They all have quite a number of long-term or of short-term toxicities, and then the long-term toxicities, doxorubicin cardiotoxicity, you guys probably are all aware of, especially if you've taken care of any patients on my studies. Thank you to all of you that have done the blood draws. Pulmonary fibrosis is one that we see from the bleomycin, and then both cardiotoxicity and pulmonary fibrosis are worsened by radiation. And so patients who get radiation that involves their heart are much more likely to develop heart failure from their anthracyclines. And then the pulmonary fibrosis, if you have any of the lung parenchyma in your radiation field, your rate of having pulmonary fibrosis and long-term issues with your sort of breathing capacity are much higher. And then the other things that we see, so secondary leukemias from the etoposide and the cyclophosphamide. And then the doses of cyclophosphamide that we use, the risk for at least high-risk patients that get a little bit more cyclophosphamide, they're in that kind of medium range for infertility risk, where I think there is likely to be some meaningful impact on infertility, probably early menopause, basically where they have less ovarian reserve. But we definitely are having conversations more even lately about fertility preservation options for these patients, and have had a couple of patients actually that pursue oocyte cryopreservation. And you know, all of the short-term toxicities, I think, are stuff that you guys are used to seeing in our patients. We give these in kind of intense cycles every 3 weeks, and they get 4 if they're low or intermediate risk and 5 if they're high risk. And then we do response adapted. So risk adapted, we're talking about we give a different sort of intensity and duration of therapy depending on their stage up front. And then response adapted is that we adapt therapy based on how they respond to therapy. So we do CAT scans with or without a PET scan after 2 cycles. And if they have a good response, then, for example, we'll take away radiation. And I sort of mentioned that there. I think this is a kind of a cool slide to where you can see how radiation therapy has evolved over time. So it used to be that radiation oncologists would radiate the entire mantle region. And so this is a lot of normal tissue in addition to the affected lymph node. And then they got to involve field radiation, where you're narrowing a little bit more. And now we're at involved node radiation, where you really are trying to narrow your fields down just around the lymph nodes. And so you're impacting a lot less of your normal breast tissue and having a lot less of this scatter to the heart and lot less involvement of the lungs. So I think that while this is helping, I think any radiation is still having some long-term toxicities. This is more just about the long-term toxicities, which I think I've already hit home. But I think this is an interesting slide that talks about your increased risk for second malignancies after Hodgkin's therapy. So this first slide is your relative increased risk. And because you know, your increased risk for non-Hodgkin's lymphoma, breast cancers, and a secondary AML. But because secondary AML is so rare that even you know, they're 150-fold more at risk than your average person, but the actual incidence of secondary AML is still really low. So the normal population, it's really rare to get secondary AML. And so even though you're 150-fold higher risk, it's still not very likely to happen. Breast cancer, however, because the population is breast cancer is so common in the population, that 50-fold increase in risk really does impact things significantly. So these patients, they're having a 30-year cumulative incidence of 15%, which is really high. Okay, and then just a brief word on relapsed Hodgkin's lymphoma. So historically, we have always thought about trying to get these patients back into remission and then getting them to an auto stem cell transplant so that we can give really high doses of chemotherapy to try to eradicate any residual lymphoma. and then you're rescuing them with their own stem cells so that they have bone marrow function after this high-dose chemo. But as we sort of de-escalate our upfront therapy, we're starting to think about relapse a little bit differently. So if you have patients that have sort of high-risk features with their relapse, we're still doing the same sort of salvage therapy and then getting them to transplant. But in patients that have had either pretty minimal therapy up front or they've relapsed with sort of like favorable features, we are thinking about trying to salvage them with chemotherapy or immunotherapy alone and not doing that auto stem cell transplant. And part of how we're able to do that is that we do have some better agents, some more targeted agents, and as I said, immunotherapy. So this is an example of sort of the three big agents that we're using in the setting of relapse, and actually both brentuximab and this anti-PD-1 class are being used in the upfront setting now in clinical trials, so you guys will start seeing those. But brentuximab it works like vincristine, so it's a microtubulin inhibitor and has kind of the same like peripheral neuropathy, sensory neuropathy kind of toxicity profile, but it targets a certain CD30 molecule on the surface of the Hodgkin cell, and so it's a lot more specific in its action. Bendamustine is an alkylator that's induced really high remission rates in the relapse setting. And then you guys have probably all heard about nivolumab or pembrolizumab. These are really popular in the adult setting where they've been able to cure incurable malignancies. But they work by shutting down or actually reactivating the kind of immune surveillance that your body is supposed to do to cancer cells. So part of why cancer can exist and grow in the body is that they figured out ways to sort of bypass the immune surveillance that should be recognizing those as cells that shouldn't be there. Part of this through this PD-1 expression. And so with these medications, we're able to sort of reactivate the immune system's ability to recognize these cancer cells as bad and then get rid of them. So, and the side effect profiles are very favorable. You can have autoimmune phenomena, which can be very life-threatening and scary, but those are a lot less common, and your average patient tolerates this beautifully without a lot of toxicity at all. So night and day from all of the chemotherapy that we're giving them. And, you know, we don't know a lot about long-term toxicity, but I think based on mechanism, these are likely to be much better in the long term. Okay, questions about Hodgkin's before I move on? Yes, Jana.
Why do you think, or is there a way to predict, some of our Hodgkins get so, like, such bad mucositis, such bad nausea, vomiting, and just it's terrible.
Yeah.
And then others are fine.
Right.
And they get the same treatment. So is there a way, is there a predictor in that, or is it just, you just see it?
That's a great question. I think some of it is driven by the difference between our high risk and our low and intermediate risk BAT. So the high risk patients do get an extra day of Cytoxan. And so I think that makes their therapy a little bit just more intensive, and they're likely to have more cytopenias and more mucositis and that kind of stuff. I've noticed that patients that have bone marrow involvement at presentation tend to have more cytopenias, more neutropenia, need transfusions, and I think along with that you can have less neutrophil support to recover from mucositis. But a lot of it is just random. Like there's just some patients that seem to be really sensitive, and you know, I had one patient with high-risk Hodgkin's that just had a miserable time, was inpatient on Dilaudid her whole way through, and then I had another patient, intermediate risk lymphoma, but did all of it as an outpatient and barely had any nausea. So I think it is really hard to explain. I will say that it seems to be the teenage girls that that struggle with constipation of vincristine or now brentuximab. And so if you guys are taking care of any of our girls inpatient, please help us make sure that they're taking their laxatives and that they are pooping every day. Because you guys have probably taken care of patients that come in with really bad abdominal pain needing a clean out. So that is a problem in this therapy. Okay, so moving on to non-Hodgkin's. So now we're going to focus on all of these subtypes on the right. So these are faster growing compared to Hodgkin's lymphoma, and so you're more likely to get kind of these emergency presentations. And so this is kind of a cool slide that I stole from a friend, but talks about sort of the A through H of your alphabet types of emergency presentations. So I mentioned this with Hodgkin's. Often this tends to be a more abrupt onset in non-Hodgkin's where things are happening more quickly, but you can have compression of your airway that's causing issues with breathing either at baseline or especially because these are often in the anterior part of your chest when you're laying down. Gravity will push the lymph mass down onto your airway, and so some patients are sleeping on pillows because they can't lay flat, which can be problematic when you guys are taking these kids to the CT scanner and they can't lay flat. One of the things that radiology should be thinking about, but if you have a patient like this that can't lay flat for their CT scan, if you lay them prone and they're actually using gravity to pull the lymph mass the other way, you should be able to get the CT scan that way, and so sometimes radiology will try that. The other thing that can happen is that you can have compression of your well, I guess this goes under circulation when you're talking about SVC syndrome. So you can have compression of your superior vena cava. That's going to lead to sort of some backup and pressure of your venous drainage in your neck. And so you can get swelling in your face. You can get this kind of ruddiness of your cheek, and that can be an emergency situation. You can also get effusions. So you can get pulmonary effusions that can interfere with breathing. You can also get pericardial effusions that can cause cardiac tamponade. And that is certainly an emergency situation. You can see arrhythmias. Often these are driven by tumor lysis and electrolyte abnormalities. Under disability, so you can with non-Hodgkin's lymphoma especially see paraspinal or epidural masses. And those can lead patients to come in with back pain or symptoms of lower extremity weakness. And so something that we always want to be thinking about. And then electrolytes, so I mentioned tumor lysis, especially in Burkitt's. That's kind of the classic thing that we think about with tumor lysis syndrome because Burkitt cells are really rapidly growing. And so you can have patients that come in already in renal failure from their kind of rapid progression of symptoms associated with their Burkitt's. But the other thing is lymphoblastic lymphomas, especially T-cell lymphoblastic lymphomas, are also pretty likely to present because they present with like big mediastinal masses and lots of kind of bulky disease, and so they can present either in tumor lysis or quickly thereafter with start of therapy. And then esophageal compression can lead to symptoms just with tolerance of PO intake. Failing organs, often this is associated with tumor lysis and your buildup of uric acid and your phosphorus and calcium precipitation in the kidney, but then you can also have intra-abdominal or intrapelvic masses that are leading to compression that's interfering with emptying of your kidney. And then GI, you can have obstruction due to nodal masses in the abdomen that are obstructing the bowels. You can have a lead point that causes intussusception from having like lymphoma in the bowel wall or nearby. And then cytopenias from marrow infiltration. And we can give steroids in the setting of an emergency presentation before we get our diagnosis. We don't like to do that, but certainly we will in emergency situations. We just want to try to really be mobilizing things so that we can get tissue as soon as possible, because after about 48 to 72 hours, you're at risk for sort of losing your ability to diagnose the cancer and knowing how to do definitive treatment. So I kind of mentioned this already, how you can present with SVC or superior mediastinal syndrome. One of the things I think for you guys to be aware of, and just knowing kind of the conversations we're having behind the scenes with anesthesia, are that these patients that have the big mediastinal masses are often sensitive to anesthesia and sedation. And you can have situations where patients who have this big mass can have collapse of their airway with anesthesia because you don't have that inspiratory effort on their own while they're awake to really try to keep their airways open. And so you can have a code event where patients are having complete obstruction and inability to oxygenate because the ET tube doesn't go down very far. And so if your ET tube gets down this far and your site of obstruction is down below it, there's not a lot you can do about that. And so they've had situations where patients like this have been have been sedated and then end up having to go on ECMO to get them oxygenated. So in any case, so anytime an anesthesiologist is giving you pushback about sending your patient to their scheduled biopsy, no, there's a reason. And so when us as the provider team are making that patient undergo like an awake biopsy, which feels a little bit cruel, also a reason for that. So in any case, yeah, talked about all that. And so this is a pretty detailed slide. I'm not going to go through all of it, but I just want to point out these are your different types of non-Hodgkin's lymphoma, and these are your different types of organ systems or sort of ways that they can present. And you can see that it varies depending on what the lymphoma is. So it's certainly not one size fits all for pediatric lymphoma. This is the staging system for non-Hodgkin's lymphoma, which is a little bit different than the one I just showed you for Hodgkin's lymphoma. It still has the same sort of above and below the diaphragm, but there is consideration of whether it's an intra-abdominal tumor or if it's a mediastinal tumor, that those can automatically up-stratify you. And the things that make you stage 4 are solely bone marrow and CNS involvement. So the approach to pediatric non-Hodgkin's lymphoma is a little different than non-Hodgkin's lymphoma. We do give CNS prophylaxis in most settings of non-Hodgkin's lymphoma, which is different. We don't do any LPs at all in Hodgkin's because it doesn't metastasize to the brain. And then it tends to be a shorter duration and a little bit more intensive. With the exception of lymphoblastic lymphoma, we do treat those kids more similar to ALL, so they get the same sort of 6 to 8 months of intensive therapy, but they also get the maintenance phase, so their total duration of therapy is 2 years. Let's see, and then the other difference is that we don't typically use radiation in non-Hodgkin's lymphoma. We will use it in your lymphoblastic lymphomas who have CNS involvement, but otherwise there's not really a role for radiation. And similar to Hodgkin's, our survival rates for all of these non-Hodgkin's lymphomas are actually really quite good, even in your high stage. Okay, so just quickly going through each of the subtypes. This is Burkitt lymphoma. This accounts for 40% of non-Hodgkin's in pediatrics. This was first described in the 50s in Uganda, and this is sort of your classic picture of endemic Burkitt's, where you think about Burkitt being associated with EBV infection. This is not the type of Hodgkin's that we see in the United States. We see this sporadic version where it's a lot less likely to be associated with EBV infection. And then the presentation, I mentioned that these are very rapid growing tumors, and so often it's a rapidly growing intra-abdominal mass that can lead to intussusception or obstruction or abdominal pain, or you can have head or neck swelling, lots of tumor lysis, and good event-free survival. And you guys have taken care of these. These are the kids that are getting COP-ADAM and those blocks of therapy, which I think I have on the next slide, yes. So it depends on your group, and your grouping, again, depends on your staging. But a lot of our patients fall in these group B or group C, where they're getting a couple of cycles of COP-ADAM. So this is like high-dose cytarabine, high-dose methotrexate, cyclophosphamide, doxorubicin, just bad chemotherapy, and they are sick. They're almost always admitted with febrile neutropenia. They almost always have really bad mucositis. They need transfusion support. And then these are a little bit less intensive, but still, if you have CNS involvement, they're getting high-dose methotrexate and high-dose cytarabine. So it's fairly intensive therapy. Anaplastic large cell lymphoma. So there's 2 subtypes. It's almost always this systemic, but you can also get cutaneous ALCL, which interestingly is an entity that can even regress spontaneously and has a very good survival. The majority of what we see is this primary systemic, and often it presents in the abdomen or in the mediastinum. You can have B symptoms, and you can have bone marrow and CNS involvement, but it's actually pretty rare in ALCL, and the survival is pretty good with modern therapy. And the agents it's similar, all the same drugs that I've been talking about throughout this presentation are all employed. It seems a little bit less intensive in terms of how sick the kids are, And the open study was a randomization between these two drugs. One of them was the brentuximab I just mentioned that's kind of similar to vincristine, and the other one is an ALK inhibitor called crizotinib. And so we're looking at adding these new agents into the intensive upfront therapy to improve survival. And I think ultimately the goal is to try to back off on some of the therapy as we maintain survival. And then I've talked about lymphoblastic lymphoma. This is probably what you guys are most familiar with because it's very much like ALL therapy. These are more often T cell than B cell, and the T cells often present in the more advanced stage 3 or stage 4. I talked about kind of this arbitrary distinction between lymphoblastic lymphoma and ALL, and I think we'll often sort of, if there's any doubt, just default to the ALL therapy because it's a little bit more intensive and it's longer. These often involve the upper torso, again with sort of rapidly enlarging neck or mediastinal nodes, and they can have respiratory symptoms from that. Bone marrow is involved in 30%. It's rare to have CNS involvement, but you can, and we do IT chemotherapy just like we do in the ALL kids. And then the 5-year EFS is also good. Relapse EFS is not so good for T lymphoblastic lymphoma. Okay, so I think that I got through everything. So we talked about the two main types and then kind of each of the subtypes within that and how those vary with age. We talked about some of the presenting symptoms, sort of the general approach to therapy, and then the sort of generally good prognosis for all of those. And I think that's all I have. Maybe I have questions about any of this stuff at all? Yes.
Would you be able to just explain why the time frame for the biopsy, the diagnostic biopsy, was so short?
Yeah.
To have those interpretable results?
Yeah, good question. Steroids are actually really effective chemotherapy or chemotherapeutic agents, and so we're expecting that the cells are dying, and as you get necrosis of your tumor, the likelihood, I mean, if you take out the entire nodal bulk, you're certainly not going to have necrosis of your entire node at that point in time. But if you're taking out just a piece of it, you might get necrotic cells. And often as they're dying, the expression of the kind of different markers on the surface of the cancer cells change. And so it can be a little bit trickier. For example, like anytime we have a patient where we do a biopsy because we're worried about relapse or recurrent disease, like for example in Hodgkin's, pathology is always sort of dragging their feet and they take a lot longer to analyze that path as opposed to a newly diagnosed patient where it can be very clear. So our treatment is sort of modifying the way that the cells are looking.
So it's just if you started steroids, otherwise there's...
Exactly,
Okay.
yeah. All right. Great. Well, you guys, if you ever see me around, feel free to ask me any questions. And I mentioned I also do cardio toxicity research. And so if you ever want to talk about that, I'm always excited to talk about it. Thank you.